I will continue with pathophysiology in diabetic ketoacidosis. So pathophysiology is quite big. So the pancreas that produces the insulin does not have beta cells in diabetes type 1 patients. So they are not producing the insulin. A lack of the insulin and lack of supply of sugar into the cells of the body will lead to secondary mechanisms for producing sugar. So it will lead to increased glyconeogenesis in the liver, and it will lead to increased glycogenolysis and glycolysis. That's breakdown of fats. All this will lead to hyperglycemia, and increased glucose in the body will cause all these things: glucosuria, polyuria, and polydipsia. Increased drinking, increased urination, and increased sugar in their urine. So also decreased insulin will lead to lipolysis, which is the breakdown of fatty acids, triglycerides, into fatty acids. Fatty acids are eventually through the liver undergoing ketogenesis will actually they become first acetyl-CoA, which is like little chains that can be fed into the Krebs cycle, but eventually they become, through the ketogenesis, they will become keto bodies. Ketone bodies, and these ketone bodies in the blood will be called ketonemia, and when they're in the urine, they will be called ketouria. The condition will be called ketouria. So that's the short version, and then the more in-depth one is right here. So decreased insulin leads to decreased ATP in the cells. All this will stimulate the secondary sources to be activated. The triglycerides will be undergoing lipolysis and become free fatty acids. These free fatty acids will undergo beta oxidation. Beta oxidation will lead to formation of this acetyl-CoA molecules. And so these molecules will be fed into the Krebs cycle, and the acetyl-CoAs that are excessive and no longer fit into the Krebs cycle, they will become ketones. Through the ketoneogenesis, they will become ketone bodies. These ketone bodies, two of them are acetate and beta-hydroxybutyrate. So acetate will eventually become the acetone, and this acetone is the one that leads to fruity breath. Okay. So eventually the ketone bodies end up in the bloodstream. This is the bloodstream. And in the ketones are converted, release hydrogens, free hydrogens. Free hydrogens lead to acidosis. So this here is now called ketoacidosis. So we have increased glucose and ketoacidosis. Ketones in the bloodstream. Increased glucose, increased ketones in the bloodstream lead to hyperosmolarity of the blood. which pulls water from brain and muscle, leading to what signs and symptoms? Confusion, altered mental status, or, hold on, let's go this way, altered level of consciousness, and weakness. Alright, now this is what happens if there's decreased insulin. Just insulin. But what if there's increased stress, increased demand? Increased stress comes from increased demand for insulin. Such as an infection or inflammation cause increased release of sugar, and the sugar cannot be pushed anywhere, so it demands more insulin, and this is the increased stress. So increased stress stimulates the sympathetic nervous system. Sympathetic nervous system releases epinephrine and norepinephrine. So epinephrine and norepinephrine actually stimulate the pancreas to produce glycogen. And glycogen affects the liver. Epinephrine and norepinephrine also stimulate triglycerides to be broken down through lipolysis into the fatty acids, and this path we already discussed for ketone bodies. So as the epinephrine and norepinephrine stimulate the glycogen in the liver, together with amino acids, lactic acid, glycerol, being converted to glucose, and glucose is being increased in the bloodstream. These lead to osmotic diuresis, as well as hyperosmolarity lead to osmotic diuresis. And since the body pees everything through the kidneys, it leads to dehydration. Where we will see the tenting, the decreased blood pressure, tenting, and decreased blood pressure. So, in diabetic ketoacidosis, which is onset less than a day, and usually occurs in type 1 diabetics, we mostly see ketoacidosis and dehydration. In people with hyperosmolar hyperglycemia, the onset is more than 1 day, and it mostly occurs in type 2 diabetics who can produce a little bit of insulin. And in them, we don't see so much of ketoacidosis, but because they still can produce a little bit of insulin, push some insulin to the cells, and there's less of that activation. So there are next to none of ketone bodies in their bloodstream. But we will see the dehydration and hyperosmolarity, because they, unlike type 1 diabetics, will less likely to pee off their sugar. So what about those ketones? So ketones, together with hydrogen, they will stimulate the chemoreceptor trigger zone in the brain, in the thalamus, to cause nausea and vomiting. Also, ketone bodies eventually are broken down, and they release hydrogens. Free hydrogens is acid. So body tries to reduce the acidity by pushing the hydrogens into the cells, but in exchange for hydrogens, the cells release potassium. Usually, the insulin will assist those pumps to push potassium in exchange for sodium into the cells, but since the insulin is not available, the body is unable to push potassium back inside the cells, and this leads to increased potassium in the extracellular fluid. This increased potassium leads to increased potassium in the serum and decreased total body potassium because body pees it out. And here we go. That increased potassium will lead to our arrhythmias and ileus. Arrhythmias, palpitations, chest pain, ileus, abdominal pain, which was mentioned earlier. Also, there's such thing as anion gap. Anion gap is when there's a positive anions are being subtracted from cations, and this is called hagma. Yeah, hagma. And it should be below 12 in a normal person. So in the where we have more hydrogens, more anions, we have more of these. Hold on. Anions are negative. Cations are positive. These ones are negative. So eventually, if there's a difference between them, and anions are like proteins and bicarbonate, all kinds of negative molecules, and cations are positive, which is our hydrogens. When you subtract them and you get a number, so it's supposed to be below 12, and in diabetic ketoacidosis it is above 12. Peripheral chemoreceptors are stimulated due to increased acidity. Increased acidity stimulates the peripheral chemoreceptors in the carotid arteries, and they stimulate the pons. Where our breathing centers are, to increase the respirations, to blow off that acidity, and the carbon dioxide, which plays part in the carbonic anhydrase chain, is being blown off, and this way the body's pH is being regulated. This leads to our sign and symptom of Kussmaul respirations. Also, since the patient is breathing off fast and a lot, that acetone from ketone bodies is being breathed out, and the patient will have that fruity breath. Dehydration. So since they are peeing out all that sugar together with water, dehydration will lead to signs and symptoms such as decreased skin turgor and dry mucous membranes. Also, dehydration will lead to decreased blood volume, which will lead to hypotension, decreased blood pressure, and decreased urine perfusion and decreased urine output. So that is dangerous. Okay, baroreceptors will be stimulated, and they will increase central nervous activity, which will lead to tachycardia and diaphoresis. So this is something we have not added to our vellum. So increased heart rate and diaphoresis. Let's add this. Diaphoresis and even maybe on the hands, some of the diaphoresis. Diaphoresis. Okay, hyperosmolarity. Hyperosmolarity. So when there's too much of the sugar in the blood vessels, it will pull the water from other compartments into the bloodstream. So we do have fluids in our brain and our muscles. If those are pulled into the bloodstream, then the glucose will be more diluted in the bloodstream, but the nervous system, the brain, and the muscles will lose that water, which will lead to weakness in the muscles and altered mental status. Even seizures or coma will be leading in the brains.